Welcome to The Value of One, The Power of All, a podcast created by the Ron Brown Scholar Program. Since 1996, this organization has been investing in the next generation of African American leaders, and this podcast highlights the stories of the people that make this program special. I'm your host, Ray Pryor, 2015 Ron Brown Scholar, and in this fourth season, we're highlighting doctors in our alumni network who have taken their training as physicians beyond just serving patients. From the moments in their personal lives that originally inspired their interest in medicine, to the professional experiences and macro trends that expanded their scope of impact as physicians, we'll peek into the minds of the leaders who are working to improve healthcare from every angle. In this episode, I'm excited to share my conversation with Dr. Travis Gayles. Travis is a member of the inaugural class of 1997 Ron Brown Scholars. After studying public policy and African American studies at Duke University, he went to med school and earned a PhD in health policy at the University of Illinois. He was a researcher at what was then called the Institute of Medicine and is now the National Academy of Medicine, as well as at the NIH, the National Institutes of Health. He's taught at the University of Illinois, Northwestern, DePaul, Johns Hopkins, University of Maryland, and NYU. He was the Chief Medical Officer for the DC Department of Health, Chief Public Health Services and Medical Officer for Montgomery County in Maryland, and Chief Health Officer of Hazel Health, the leader in school-based telehealth that partners with school districts and health plans nationally to provide mental and physical health services to K-12 students where they are, at school and at home. Now, he's the president and CEO of Howard Brown Health, a nonprofit LGBTQ plus healthcare and social services provider with an annual budget of $145 million that serves tens of thousands of patients in the Chicagoland area. Take a listen.
When was the moment that you knew that you wanted to be a doctor?
I remember actually I was in fourth grade and we had to write paragraphs about what we wanted to be. And this was back in the day where you had hard copy encyclopedias. And we had the 1981 edition of World Book Encyclopedias. So I went to the encyclopedia, was like, I want to read it, like, what's a doctor? And like write my thing around that. Well, there was no entry for doctor in the encyclopedia. And so I was like, well, I can't write something. I don't know what entails, what fully goes into that. So I actually wrote my paragraph about being an architect because there was an entry about being an architect within that space. But that interest never died. And so I always enjoyed science. I enjoyed biology, mostly in thinking about the human body. And when I got to high school, there was an opportunity to do a summer program in Virginia. It was called the Governor's School. And one of the Governor's Schools, they had a program for, I think it was 30 high school students at MCV and Medical College of Virginia. And you were paired with a physician for 6 weeks. And so you shadowed that physician, you went to lectures, you got to meet medical students, you got to be exposed to the hospital and primary care environment. And I ended up applying for it as a sophomore and got in. And spent the summer with Dr. Thomas Loughran, who I think is still practicing as an orthopedic surgeon and sports medicine doctor, and just was blown away by not only the science behind medicine, but just the ability to connect with people and how his ability to translate his brilliance and his clinical knowledge to making people feel better. And that spanned the spectrum from the person who came in and had some foot pain and just needed an injection or a brace to the more, complicated ACL reconstruction type operation that got that athlete back to being at full speed and being able to compete. And so that experience crystallized that early interest in medicine because it helped show that medicine was an opportunity to marry those interests of the hardcore science, but also that service piece in helping make other people feel better.
Yeah, these critical exposure moments early on in life. Certainly you have other experiences later in life, but nothing has the same compounding impact as it sounds like that shadowing experience did. And to have that in high school is powerful. What were you thinking about in college at Duke? And I'm assuming you're pre-med. I know you studied public policy as I did and probably had a lot of different interests. What was top of mind for you in terms of your career? Was it pretty hard set that you're going to be a doctor the whole time, or were there other things that piqued your interest, at least for the time being while you were there?
Well, it's interesting. Building upon that experience with Dr. Lockren and being exposed to orthopedics, I started Duke as a biomedical engineer in a pre-med with the vision of becoming an orthopedic surgeon, doing joint replacements and creating artificial materials that could be used for enhancing joint replacement surgery. That's what I wanted to do. So I did that for a year and a half and discovered that um, there was a lot more electrical engineering involved in biomedical engineering that I had zero interest in learning about and pursuing. And I had a long conversation with my advisor who said, well, you've done all of your pre-med stuff. If this isn't for you, let's look at what other things that you have done and excelled in while you're at Duke. And he highlighted, he's like, all of your electives are actually in public policy, political science, and African American studies, and their grades are good in that. He's like, why don't you think about majoring in one of those? And at that time, I had taken I think it was Introduction to Health Policy course as one of my first public policy classes, and was fascinated by, health policy, the marriage between public policy and legislation and advocacy with the healthcare component. And I met Dr. Kate Wetton, who was the professor of that class, who went on to be my advisor at Duke. And actually, fast forward when I was in my PhD program, was on my dissertation committee, and we still continue to work together. And she serves as a great source of advice and guidance to me as I've moved through my career. So as I transitioned into that space, this was the late 90s where public health really wasn't known too much outside of restaurant inspections, health department world. And then 9/11 happened and bioterrorism happened. And so public health got a lot of attention. And so you started to see a transition of public health programs span, beyond just a couple of different programs across the country. And the challenge I had, though, is I loved health policy, really was engaged in it, but I was like, I still like medicine. So, which one do I pursue? So I actually took a couple of years off after college to figure that out. I was like, do I go the route of, go to grad school in health policy? Do I go to law school and do more of the health policy route that way? Or do I go to medical school and get an MPH and figure out some way to integrate public health into my clinical practice? And my first job out of college actually was coordinated in some ways through a friend of the Ron Brown program. And I got an opportunity to work it was then the Institute of Medicine. It's now the National Academy of Medicine, as a research assistant on one of their studies that looked at improving palliative and end-of-life care for children and their families. And so got to pursue my pediatric interests as well as see how, the committee members were physician leaders who were engaged in policy and advocacy. And I would sit in meetings and think, this is it. That's what I want to do. That you practice, but then you bring that practice to the decision-making table to craft policy and advocacy. And so it crystallized that was the route to pursue. And I ended up applying to places. And there was a program at the University of Illinois that at the time you could only get financial support for MD PhD programs if you did a PhD in a biomedical science. University of Illinois had a different program. You could actually get a PhD in any of their graduate programs and get funding for it. They happen to have a graduate program in community health with a health policy focus. I applied and ended up getting in, and that's how I ended up in the career trajectory, at least from that stage, the dual degree program that let me not have to pick one or the other. It let me pursue both.
I wanted to dive back into two things, and then I certainly want to talk about your time at USC. It sounds like your at least initial focus was peds as a clinician. Tell us a little bit about why and where that came from, and how you came about to that decision.
Well, in my opinion, I think children are resilient in a way that we don't give them enough credit for. And they make for great patients. They listen to you, probably more so than adults, particularly when it comes to healthcare service delivery. I am personally fascinated by pediatric pathophysiology. So disease processes, because in pediatrics, you get, when kids are born, you get the impact of, genetic illnesses, some chronic disease, you got accidents, prevention, public health, vaccines, population health. You really do bring all of those together in the pediatric space in a way that I don't think you really get to do in adult medicine. A lot of adult medicine is more just chronic disease management, which is necessary and needed. But for me, just the pediatric pathophysiology was far more fascinating. And from the social justice perspective, I think of pediatrics as a way, there's a lot of stuff wrong in the world. There's a lot of isms and phobias. But if you can get a kid healthy, you can create some type of baseline that at least when the kid enters into those spaces to combat those issues, you're at least healthy. And I think we know that when kids are healthy and whole, they can show up in the classroom and perform better. We can be better citizens, less likely to take risks that put them and their friends at increased danger. And so I look at pediatrics as an opportunity to at least get them started off on a solid foundation, to be able to combat those different influences that they might be exposed to as they encounter the rest of the world.
Yeah, thank you for sharing that. It's one thing to go to med school, particularly when you're exploring all these other ways that you can have an impact. And it sounds like this dual program was perfect for your interests. Tell us a little bit about why, and it might have just been the programs available, but why PhD specifically? It sounds like you got some research exposure. Did you see yourself long-term being an academic as well? Or what kind of drove your interest in the PhD doctoral program specifically, as opposed to any other degree you kind of could have coupled with?
One of the interesting experiences I had when I was at Institute of Medicine, this again was early 2000s, before we really had more sophisticated language and data around health disparities and health equity. And I remember having a conversation where we were discussing, one of the chapters in the book dealt with the demographics of like, well, who are these families? What are the causes of death? What are the causes of illness? And we had a conversation around, well, are there any disparities by race and disparities by geographic location? Because we know that systems look different, whether, whichever state you're in, what zip code, that kind of thing. And there was a realization that, yes, that's an important topic, but nobody has the data on it. And I remember thinking, oh, wait, well, I would love to be able to get the training and tools to be able to ask those research questions and get that data so that whether we're talking about end-of-life care or whatever issue, the right questions have been asked and the right data is available to be not only included as a part of the discussion, but be included as a part of that policy formation. And so that's one of the things that pushed me to say, well, a PhD program would get that research training. It would get that, the statistics, the epidemiology, the research practice, that kind of thing that would equip me to, in the future, be able to pursue NIH funding or CDC funding to be able to ask those questions that were pertinent to the communities that I belonged to and that I lived in. So that data, the absence of data would not be prohibit those questions from being asked and policies from being formed. Now, I did not think it would be through a PhD because, interestingly, going back to that high school program, when I heard about people doing MD PhD programs, I'm like, those folks are crazy. Why would you want to do that? That's a long time. When I took a couple of years off working after college, I realized, well, the real world ain't all that either. So, if I'm going to be in grad school a couple of years, I'm at least pursuing what I really am interested in and driven by. And I'm thankful for that experience because it helped me think on a higher level critically around how do systems move and what contributes to policies being made and what gets prioritized and how to, again, ask questions in the right way where you get the right data to be able to inform policymakers, to be able to drive them in the direction that you want them to go as it relates to the work that you're doing. Now, when I did it, I pretty much was pretty sure, academics is the career track because that's where most MD PhDs go. And I did start in that pathway, but being exposed to different opportunities, meeting different mentors and having different experiences, I also began to learn that there were other pathways out there that I could apply that skill set to and still be just as impactful, still be just as engaged in the community, and be just as relevant as a part of those larger conversations about the issues that were important to me personally and professionally.
Yeah, that's great. And this might be leading down to some of those things that caught your interest of alternative ways to have an impact. I know you spent a lot of time teaching, and you spent a lot of time, as we'll talk about, Hazel Health and in what we might call a health startup world, and then also in leading an organization as well. But you've also spent some time, in leadership of the public sector too. The origins, like you described, of where the original idea of public health was a very public thing. It wasn't necessarily something that was pursued, at least at the scale now, for startups or other organizations. What were some of those experiences, and what caught your eye about wanting to try to move the needle on some of these larger public institutions versus perhaps finding anything else that you could have done?
Where do we start? We could separate COVID from all of it or just talk about, it's all wrapped in one. Well, I think at the core, when looking at larger public health systems, there is so much opportunity and potential to do good because you are creating the health system for everybody. It's not just that we got a health system over here. If you've got the right type of insurance or the right type of benefit, you really are creating policy that applies to everybody. And so in some ways, it's a great opportunity to ensure that equitable access and comparable access to resources are granted. And that's something that we definitely leaned in and were very intentional about as we built out our COVID response at the health department, whether we're talking about access to testing or ultimately access to vaccines, particularly when it was early on where we did not have a lot of supply available. And we had to figure out how to distribute vaccines in a fair way that allowed for comparable access across all communities, regardless of the zip code you lived in or the insurance type or ability to pay that you had. Now, there are certain challenges that being in the public health sector that I've learned from, that I have taken with me as I've moved forward in my career. One of them is when you're in government, most times, or at least my experience was, I think every budget I had had a budget cut. So it was always, how do you increase the impact that you have while recognizing that you're going to have less resources in doing that. And one of the mantras that I always promoted to my teams was, cuts aren't necessarily a bad thing. They force you to look at your models and to see, are they efficient? Are we maximizing capacity and not just hiring extra people to throw at work? And how are we being more thoughtful and strategic around forming partnerships with others to be able to do the work and be able to share some of the financial burden and load? And the other thing too is that is a little tricky about the public sector in more ways than the private sector, is when things are going well, nobody knows you exist. So for example, if things are going well, nobody really pays attention to public health. You're coasting along, no diseases are spreading, restaurants are safe, we're behind the scenes. Now, when that gets to a point like a pandemic where it's more public, folks scrutinize what you do a lot more. And unfortunately, that scrutiny isn't always coming from a data-based, evidence-based practice. And that can be challenging when you are operating from a space where you are trying to do the best for your communities and by your communities because you're representing everybody who lives in your particular space. And not everybody's okay with that when they're like, but that doesn't apply to me. I'm in a different situation. And getting people to understand you're trying to make policies that apply to everybody, not just a select few. And I think that's one of the things that left a lot of us who have been in public health for a long time. It hurt and left some scars. But they're learning lessons too that I think will hopefully allow us to be able to transform the public health sector so that when we are in a space where we have leadership that believes in science again and believes in the power of public health, we will be able to create more systems that are sustainable and modernized to be able to meet the needs of the people we're serving.
Yeah, on that line, across variety of industries and spaces, there are a lot of things changed with the pandemic. And what are some of those things in the public health realm that you think the profession or folks who are interested in this have not learned or maybe failed to remember that we should keep top of mind from the pandemic that perhaps maybe now, uh, I guess a little over 5 years out from what, you can call the official beginning of it, might lose its sensitivity, not like it did a handful of years ago.
One of the lessons that I learned and hope I don't forget is that I think in the public health world and the clinical world, just clinical medicine practice, is we are so evidence-based driven. We're like, here's a practice, here's a policy, here's the data. If this, then that. Medicine is all about protocols that are evidence-based and lab tested and those kinds of things. I think sometimes we forget to be able to translate that into a way that people who don't have that background understand. And so, for example, I think one of the things that we struggled with from a public health perspective through COVID is being able to message why it was important to do certain things or have certain rules in place and be able to translate or like, I know this might impact your job or this might impact your kid going to school or this might impact activity X, and being able to bridge that gap a little bit more around saying, well, this particular policy is going to prevent X amount of people from getting sick and X amount of people from dying. Clinicians are like, I get it. Great. Understandable. Population health. We get it. Understandable. We're keeping people alive. But that doesn't necessarily resonate with everybody. And so being able to be sensitive to that, but be able to translate and form more of an understanding to say, I understand why this policy may negatively impact you. But the reason why we have to do it is because of this, it's saving lives or keeping people healthy. And by the way, also impacting this particular area of your life. And so I just hope that as we continue to move forward, because unfortunately, I think we have lost some people in the audience around the importance of certain practices because now they just see it as it's taking my liberty or it's impacting my ability to function negatively. And they're not even listening to the fact that this may be saving their life or someone else's life. And so I'm hopeful that as we continue to move forward and have serious conversations about public health threats and disease spread and control, is that we're able to have more nuanced conversations so that people understand why certain practices are in place and certain practices are necessary. I think in the absence of that, we're going to get to a space where, God forbid, we have a massive outbreak of some preventable disease that kills a lot of people because they didn't trust the science or understand the science, if you will, behind why certain things are decided and necessary.
Yeah. I even recall myself getting, what is it, a very base level education, but when I didn't have, even just seeing the numbers when you watch the news of how many people are infected, how many people passed, what kind of like you're describing the messaging around the why, and it's just not a space that people think about day to day when they're going to work and dropping their kids off. And even so, when you're saying saving lives and to in a framework that certainly resonates with your peers, there's a level of scale, but also a level of familiarity that yeah, it takes some teaching, takes some learning, and I think it's great that you wear that responsibility that it's your job to help the public understand that, and certainly even when you might disagree with some of their actions, you have a bit of empathy for why they do what they do and how they think about things.
The challenge is it can become very depersonal, like, well, I know that those people are impacted over there, but I'm okay over here, so why do I need to do that? And I mean, I think there are two instances during the pandemic that stood out that gave me like physical pause. I remember when they happened, like I was physically moved where I had to stop. Like I felt movement, if anybody can understand how I'm trying to describe that. The first one was when we were concerned about having enough morgue space if people died. And so I had to make the order to order refrigerated trucks for each of the hospitals to have if, they needed that space. And the second one was when in the early stages of COVID, data systems weren't very sophisticated. Fax machines, we were getting daily faxes of negative test results. But when I got the first spreadsheet from the State Department of Health around the folks who had died within Montgomery County, and it was a spreadsheet that was, by the time I received it, it was over 500 folks. And it had their names, their date of birth, their address, their occupation, their next of kin kind of thing. And it was powerful because it shifted the conversation from like, well, we had 20 people pass today, or we had 60 new infections today, as it was listing people's names and like such and such was 65 years old. They were a retired teacher. And it personalized it in a way that resonated with me. But going back to, if you weren't seeing that regularly, you weren't seeing how that impacted you. And that's a piece where I think that allowed for more disconnection when it became, as we moved through the pandemic and we're asking people to do different things, it made it easier to be like, well, I'm not saying that, I don't know that. So why do these things have to apply to me?
Yeah. I even moved during the pandemic, but lived in states or even visited states over the last 5 years that handled the pandemic very differently than each other. And I was wondering if you could shed some light on the federalism structure of public health. Who is in charge of making these decisions as it relates to different policies or rule changes that we need to have around public health? And certainly there's people on the ground who are executing. Do we as a country need to all be on the same page and look to the federal government to make these decisions? Or is there kind of like a chain of command that then spreads out power? Because I just felt that different people, depending on what city you were living in, had very different experiences on what masking or social distancing or quarantining meant, or meant nothing at all, really, for you, where you were.
Sure. Well, I think it would be a great case study, actually. You could teach a whole course on the COVID response and that specific question that you just asked. In the very beginning, everyone was on the same page. It was the CDC makes determinations. The CDC has guidelines to determine who gets tested, where those tests go. I remember early stages, we had to collect the swabs and send them directly to the CDC to get observed. And have those tests run. So in the early stages, yes, there was a federal response, which is how historically things have worked. Now that became more complicated as things moved forward and there was fatigue around being closed down. And so that's when you started to see conversations pop out around, well, who has the ability to make those decisions around continuing those policies, from everything around masking to school closures to requiring vaccination, all of those things. And that's where you saw a high variability in terms of how responses were driven. Historically, there have been policies that have been universal across the country, vaccinations and immunizations, core public health practices around, levels of contaminants in water supply and different things like that. I think, unfortunately, a result of COVID is that there is going to be more of a push to localize those responses. Which can be very tricky. It can be highly variable, again, dependent upon where you're living. And this is not me just as a pediatrician or clinician. I think there's certain things that we should all be able to agree upon are good and bad. Like, water cleanliness and lead in water and things like that. But I do think as we move forward, there will be more of a push for more localized control over how those decisions are made.
Yeah, interesting. Let's shift forward to Hazel Health. Can you tell us a little bit about what Hazel does and how you joined, and what about what they were doing was exciting for you?
Yeah, so Hazel Health is the nation's largest telehealth provider that partners directly with schools. Hazel Health partners directly with schools to offer either physical health and or mental health through a telemedicine platform that is typically utilized in the school setting, and also sometimes at home, depending upon the partnership with the respective district. After being in the public sector, in the health department world for a number of years, I had planned to stay. That was similar to academic medicine. I had planned to stick with public health, but I was approached actually got a cold call from a recruiter on LinkedIn to say, hey, based upon your background, I've got this really interesting opportunity with this startup company. They're looking for someone to oversee their clinical team and health team. And I think you should have a conversation with them. And, I have nothing wrong with having a conversation, like it sounds kind of far out there, but all right, why not? And in having the conversation, again, as someone who equity, access, all of those things are important. In meeting folks from the team, I started thinking, I'm like, they have venture capital money and they're trying to increase access to care for kids and they can do it in rural and urban areas. This seems, and I can spend your venture capital money and I don't have to get budget cuts. So fast forward after a series of conversations, and also just the idea of being able to have a scalable solution that wasn't just local, it could be applied literally in a small rural district versus, an inner city district. I was fascinated by that. And it was also, I was enough in my career to be seasoned to take that kind of role, but also be young enough to be nimble and to learn some new skill sets. And for me, one of the things that was important to get out of the experience was understanding how to translate a social driven mission into a sustainable financial business model that met the needs of the community, but was also something that kept the lights on and prospered. And so I knew that it would be a good learning experience, an opportunity for me to bring my background, but also be exposed to folks who came at things from a different lens, particularly from a business, venture capital, technical lens. And so that's what got me interested. And fortunately, it worked out that they were interested in me. And I joined back in September of 2021.
And, you've seen a variety of angles in which you can deliver healthcare. You've seen it as a student and as a resident. You've seen it in the public health sector side. What about delivering healthcare through, maybe not just through telehealth? I mean, there's a lot of different lenses we could do this, but what about just the nature of doing it through a for-profit startup that's venture-backed? How do you think about, if at all, maybe you don't think about it any differently in terms of delivering high-quality service, but are there any differences in how you think about structuring a system to deliver service well that maybe you get to do in the startup that you didn't get to do when you were running things at Montgomery County, or don't get to do when you're a clinician at a big hospital?
Well, I mean, some of the things were still apply. The same thing from the government to private sector is you still have to be able to present a model that is sustainable, whether we're talking about government funding versus venture capital funding. And everyone's looking to see their return on investment and to see impact. And so one of the things that we really pushed were being able to, when we came up with ideas, really being able to have measurable metrics that could demonstrate why that particular proposal was a benefit and resonated, not only in creating impact for the client, being the kids and their families, but also show clear return on investment for any of the folks, funders, and supporters of the company. Um, it was not always easy because, again, as someone who has historically been population health, public health, it's all about the social mission. There were times where I really wanted to push an initiative where I'm like, oh my God, this would be great. Where I had to understand, we're like, yeah, but that's not financially viable. It's like, great idea, but good luck sustaining that. So forcing me to build a different muscle and way of thinking around how do you still preserve that social mission and translate that into a space where it is attractive for potential funders. It is attractive for growth opportunities, and non-clinical people don't see it as, risk averse as they might when, you're proposing the idea.
Related to that shift in mindset was needing to think through the financial viability, at least in a different way than you would leading in the public sector. Was that a challenge that you welcomed and were excited about and felt that made your ideas better, and that you knew that you had thought through how this was going to sustain itself and lead to the impact that you have? Or did you feel that you were having to change yourself or fix yourself into a box of there's all these things that I want to do. And certainly I care mostly about people, but I have to only do these things because these are the only things that are viable. I guess how did you balance that internally for yourself? And because I think depending on what perspective you take on those kinds of decisions might inform how attractive you are to that kind of work, the value you see in it, how long you stay. Just curious to hear what you think about that.
Well, interestingly, I'm actually going to pull from an experience I had as a Duke undergrad from my fellow Duke person. I took a course with Bill Raspberry, who I first was introduced to through the Ron Brown program, was a friend of Ron Brown, and discovered that he taught 2 classes a semester at Duke. And the first class I took with him, actually it was the second class I took with him. It was a class on race and equity. This was, I think, 1999. And the first day of class, he said, I'm telling you what your final is already, so just get prepared. He's like, you will write 1 paper for affirmative action and 1 paper against affirmative action. And he said, because the goal is whatever your opinion is, you should be able to think critically on both sides. And by thinking critically on both sides, that will likely strengthen how you feel, but also give you an opportunity to think about how those who have different views feel about it. And so I take that approach with me through my career, thinking through, I have my point of view and I have my opinion, but it's important to get exposure to the other side and to think how the other side thinks and to learn, because that actually, I think, in many ways strengthens your resolve and strengthens your approach. And so to your question, to apply that to your question, I looked at it as an opportunity to get that background and get that training to strengthen those ideas. Fortunately, I was never asked to conform any of my ideas or fit into a box. It was more of, okay, let's think about what does that look like if we were to scale it up? How would that look like if we were to apply that over a large number of districts or a large number of kids? And so to me, I saw it as adding an extra layer of rigor to strengthen the approach. And it's certainly one of the things that, in my current role, navigating fiscal responsibility, navigating compliance with the federal government, and navigating being just a good care provider and service delivery model for the patients we serve, it comes in handy when being able to stay connected to a social-driven mission, but also understanding the realities of keeping the doors open, making sure that we have a mission to deliver to the patients, and also thinking about growth opportunities to, expand the scope of what we provide and the services we provide.
Yeah, for sure. I definitely want to shift to that in a second. I have one more question about Hazel Health that I think other folks might be interested to hear. A lot of things that the Hazel Health and y'all are doing that are not the traditional venture capital backed startup framework. It's well understood that selling to schools is a very hard thing to do, and most people shy you away from doing that. My hunch is that you not only have software that helps you do your work well, but you also need some sort of hardware, technology, product, something at the school for you to engage with the kids and with the folks who are on the ground. So there's a lot of moving pieces that normally people say, no, this is what makes doing this kind of thing hard to do. Certainly with venture expectations. Can you walk through a little bit about how Hazel Health does what they do and what is the business model and why is it possible that this company is able to increase access to healthcare using technology and do so in a way that doesn't rely on the normal sources of funding that most folks who care about this need to rely on?
One of the great parts about children's health is that children's health, particularly access to mental health services, is one of the few issues that pretty much everybody agrees on is important. So across political ideologies, across political lines. And what's interesting is, Hazel partners with some states, red states, blue states, progressive, conservative, big district, small district, because everybody agrees it's important for kids to have good health care. It may differ on how the model and approach to it, but I think it's one of the few issues where we can say, we need to do right by our kids. Now, so I think Hazel's been able to tap into that spirit, and as a result of that, has been able to leverage and form partnerships with different groups to be able to craft funding opportunities, to craft pilot opportunities, and, some creative strategies around increasing access to services. I think one of the other things too is being able to data always is important, being able to clearly show how having access to healthcare services can improve students' attendance rates. And that is important where, particularly in states where school payment and school funds are directly tied to attendance rates. And we know that when kids are healthy, they can focus in class. And so there is likely a correlation, a one-to-one correlation or a strong correlation between the ability to be healthy and present in the classroom and a child's academic performance. And I think those are, again, metrics that no matter what political party or ideology you have, I think we can all agree upon are important indicators to demonstrate that we're doing right by our children. And so I think being able to tap into that spirit and be able to provide a viable option makes it easier for schools because they're like, well, yeah, we want to do those things for our kids, but we don't even know, how do we go about doing that? How do we build the technology? How do we do that? Hazel's been able to step in and say, here is a viable alternative that does not require you to do a heavy lift as a district outside of obviously providing the funds to be able to extend those services to kids and thereby have those other benefits of increased attendance, increased academic performance, less behavioral concerns because kids are linked to behavioral health services and things like that.
Yeah, certainly it's not easy work to do and has its own complexities, but certainly is an area that for the most part, all incentives and values are aligned, at least more so than perhaps other issues, certainly other areas of public health and Hazel's been able to execute well there. Very cool. Tell us about Howard Brown Health and what about the opportunity to lead there excited you coming out of, I guess seemingly a very similar ethos across every space you've ever been in, but a very different environment likely than Hazel Health has been.
Yeah, well, part of back in the fall of 2024, as you know, there was an election happening, an interesting political environment. And one of the things that I have been asking myself was I doing enough to leverage my skill set, subject matter expertise, and experience to benefit the communities that I belong to, broadly defined by who I love, what zip code I live in, and so forth. And I had been searching for opportunities most of them volunteer opportunities to connect and give back to the communities that I belong to. And similarly, a recruiter out of the blue said, hey, could you provide some insights into this role? Do you have some folks that you would recommend who are interested? And I said, well, here's some names. I'm good over here. And they came back about a month later and said, actually, your name has come up in a few of the conversations. Would you be open to a deeper conversation? And that was also right around, this was like the election was heating up and feeling that sense of what am I doing to be a part of the resistance, if you will. And what also attracted me and interested me about the role was having been in the health department, but then also having been on the venture capital side, seeing the potential and need for modernization and a federally qualified health center type model. I think, unfortunately, when we think of health departments or FQHCs, those types of things, there is almost this inherent expectation that it's a second class layer of services, or it's not going to be on the same level, or technology just didn't quite get there. I refuse to accept that and looked at it as an opportunity to say, hey, how can we build really a modern enterprise that, yes, isn't a federally qualified health center, but is top tier, so that whether you're walking into the doors of Howard Brown or to Northwestern or University of Chicago or Rush, any of those places, you can have the same level of expectations in terms of the quality and access to scope of services that you're going to get. And so I have been intrigued by that opportunity to push that. And then certainly the election happened, and I was intrigued and continue to be intrigued by the opportunity to continue to support a mission that is open to providing services for everyone, but has also historically been a major provider of clinical resources to the LGBTQ plus community that is disproportionately being, attacked and assaulted by the federal government when it comes to funding, support, all of those things. And so I look at it as my own form of resistance, an own form of protest, as well as an opportunity to build something and grow something that truly is an enterprise that builds on its history of services, but redefines how we think of clinical models. It redefines how we think about taking care of people living with HIV. It redefines what we mean when we talk about women's health. It redefines what it means to create meaningful access for communities that have historically been in health deserts. One of our clinics is located in the Inglewood neighborhood, where the life expectancy is in the low 60s. Our flagship building, the newest building, is located in Lakeview, where the life expectancy is 84 to 86 years old. So how can we leverage our clinical resources where we are leaning on our history, but also changing the way that communities that have historically been underserved, connecting them to services in a meaningful way, and literally moving the needle on their life expectancy? Because I think 60 years old is too young to die when it can be prevented if you've got access to meaningful care.
Great. Well said. Um, just to wrap up here, there's so much going on now, and then perhaps there always is, but maybe it's just feels different now that you've got everything around artificial intelligence. You've got all the changes in federal government that you described. We're coming out of a pandemic and trying to fend off new ones, and uh, there's just a lot of things that all are outside of medicine that impact your job and the job of doctors. What message would you have for uh, the residents, the students, the pre-med folks who are figuring out where do they fit in this very vast ecosystem that, as you've laid out in your story, that you can pursue a lot of different pathways and there's a lot of different things to consider? Anything that comes top of mind that you think should be their North Star or perspective to keep in mind as they kind of make different decisions throughout their career?
Obviously, I mean, it's important to have a vision and it's important to have a goal. But I think the other thing is, it's as evidenced by my career, and I would say there are ample Ron Brown scholars who are doing far more fabulous things and amazing things who've taken different routes. And I think that's the important thing is that there are more ways than one way to get to the destination of where you want to go. And while there are a certain amount of class, like you got to take these classes if you want to be pre-med because you got to be able to take the test and do that. But it's also important to pick up other skill sets too that you may not think of intuitively that are going to be part of building your success in the future. And sometimes that means putting yourself in positions that stretch you out of your comfort zone. For example, I went to Hazel skeptical of a business first approach, but I knew it was important for me to get those skill sets and understand how to be a part of those conversations and translate that. And now in my current role, that's an advantage I have when I walk into some spaces and being able to bridge the more social driven side, but also be sophisticated in conversations around business models, understanding financial concepts. So I would say, do what you got to do to get to your goal, but keep yourself open to other learning opportunities because you're going to pick up different skills that will carry you far and be very valuable. And I liken it to, I have my nephew plays baseball, and watching him grow up, he's now a junior in high school. One of the things that, my brother's always talked about is having him play other sports, even though baseball is his primary sport, having him play other sports because he's picking up different skills and building different muscles. I think that's the same thing to think about is being nimble and flexible and exposing yourself to as many learning opportunities as you can. Because one, you'll learn different skill sets and you might find something to be like, well, wait, I actually like this. That was kind of me with health policy. It's like, wait, I didn't think about this, but now that I know about it, I want to learn more about this. And so that created an avenue to, eventually put me on a trajectory that allowed me to marry those two interests, which now when I'm sitting in the seat of my role now or my most recent roles, Yeah, it all makes sense because I'm pulling together all of those different skill sets that I pulled from all of those different learning experiences.
Thanks for listening to this episode of The Value of One, the Power of All, a podcast created by the Ron Brown Scholar Program. If you want to hear more inspiring conversations like this one, don't forget to click subscribe on your favorite podcast platform. To learn more about the organization, check us out at ronbrown.org.